Hi again, welcome to my Ed Talk. Today we're going to talk about ischemic heart disease, and we're going to specifically talk about what the gold standard is for acute versus chronic ischemic heart disease. How do we diagnose this or look at this? And we're going to talk about what we're going to ask the patients preoperatively about their ischemic heart disease. So, acute ischemic heart disease, the gold standard for evaluating this is a coronary angiography. So these patients are going to go to cath lab and they're going to inject some contrast into the proximal aorta here to visualize the coronary arteries. And this is going to assess for occlusions. It is a definitive diagnosis. It's going to answer if there are any blockages, where are they, and how much or how severe are these blockages. So an example of this here, I put some pictures up here. This is a right coronary artery stenosis. This is a left circumflex. And this is a left anterior descending. And so the cardiologist is going to be able to look at the occlusion and try to figure out what the best treatment is for this patient and how can they restore the perfusion. The next one we're going to talk about is chronic ischemic heart disease. So for chronic ischemic heart disease, we're going to look at 12-lead EKGs. Why? Because we want to be able to compare their past EKG to their current EKG to assess if there's any worsening or progression of ischemic changes. So a 12-lead EKG, we have a person getting one right here. There's going to be 3 types of leads: the limb leads, augmented leads, and precordial. Limb leads are going to evaluate conduction pathways. Augmented leads are going to look at the axis, and our precordial is going to localize ischemia. This is what we're more looking at here. And here's an example of a 12-lead. I just kind of found a picture that color-coded the different leads and what part of the heart they're associated with. And down here, you see a EKG, 12-lead, and they've highlighted 2, 3 AVF. And what type of MI is this? This is an inferior wall MI. Next, we're going to talk about what are we going to ask our patients. So we want to know, first of all, do they have a history of ischemic heart disease? We want to ask our patients what their exercise tolerance is. Are they stable? Are they able to walk up a flight of stairs without getting tired or winded? What we're looking for is a functional capacity of greater than 4 METs. And then we're going to see, do you have a history of the MI? And when was it? Has it been less than 6 weeks? And then if they have had a history of MI, we want to know, were there any stents placed? We want to know if there were stents placed, what type of stents were they? Were they a bare metal stent or were they drug-eluting stent? Because we have to remember that the dual antiplatelet therapy is different for the type of stent. So are they done with their dual antiplatelet therapy? For bare metal, it's going to be 1 month of antiplatelet therapy, and for drug-eluting stents, it's going to be 1 year. And then are they on chronic anticoagulation? Usually for bare metal stents, they're going to be on chronic anticoagulation, and for drug-eluting stents, they will not usually be on chronic anticoagulation. Then we want to know what comorbidities do they have. We want to know, are these patients diabetic? Do they have any other issues that are going to worsen their history of cardiac ischemia? We want to be aware of them and make an anesthetic plan that's going to cater to these issues. And then finally, usually when someone has ischemic heart disease, they're on some type of beta blocker. And so we want to make sure that they took their beta blocker the day of surgery, because if they haven't, we want to give it to them as soon as possible, unless there's any contraindications to receiving them, such as a low heart rate or hypotension. Thanks for listening.